Okay, that's what everyone in.
Okay, thanks. We'll give another 30 seconds or so. I'm enjoying looking at this title slide. Okay, well, I think we probably should get underway. We've got a very multidisciplinary couple of talks today that look particularly interesting. So I'm delighted that Greg Murrow's first up. Greg's a cardiac electrophysiologist from Papworth and is talking about cardiac arrhythmia. Greg, over to you. Thanks.
Thanks, Ken, and thank you for the opportunity to speak this afternoon. So yes, my talk is titled Things That Go Crash in the Night, Tales from the Inherited Arrhythmia Clinic. To give a bit of context on this, the phrase things that go bump in the night has long been associated with supernatural phenomenon and ghosts and ghoulies who awake in the night and cause all sorts of mischief. It probably dates back to this Old English or Old Cornish poem, from ghoulies and ghosties and long-legged beasties and all things that go bump in the night, good Lord deliver us. More modernly, Tales from the Crypt was a 1980s and a 90s TV series where a presenter or a storyteller oversaw an anthology of stories featuring various things that go bump in the night. And the idea is that these were very scary stories. Now, personally, I've never been much of a horror film fan. I'd much rather watch a comedy. But what I would like to talk about today is something I think is genuinely terrifying, and that is the sudden and unexpected cardiac arrest of a young and otherwise healthy adult. This was a headline from the Cambridge Evening News regarding one of our patients from 2019, and I'd like to show you a photograph that was associated with this story. This is David. This is David on our critical care unit in the first 24 hours after his presentation. As the tagline says, his wife noticed that he was breathing abnormally during the middle of the night. He rolled out of bed and collapsed on the floor, and she performed prolonged resuscitation before the paramedics arrived and thankfully defibrillated David. He was transferred directly to Papworth, where he underwent immediate coronary angiography, which was unremarkable, and then had a 48-hour stay on our ITU before thankfully waking up and making a full recovery. And we'll come back to David's story shortly. Unfortunately, not all cardiac arrests survive like David did. This is some promotional material from the charity Cardiac Risk in the Young, who provide bereavement support to families who experience a young sudden cardiac death, and also advocate screening of young adults to try and prevent these deaths. They say that 12 adults will die every week in the UK from sudden cardiac arrest. That figure is based on this study by Michael Papadakis, published more than 10 years ago now, where they looked at 3 or 4 years worth of death certificates data from the ONS and tried to identify from a death certificate which of these deaths could be attributable to sudden arrhythmia. Similar studies were then also conducted in other countries in Europe and around the world, and they came to a consistent figure of around 1 in 50,000 person years as being the risk of sudden cardiac arrest in young adults. And the majority of those do occur during sleep. This is data from a large post-mortem study. So these were more than 700 cases of sudden cardiac death where the post-mortem had been unremarkable, so no abnormalities found structurally with the heart. And almost more than 80% of those deaths had occurred during sleep or at rest, with a very, very small minority being triggered by exercise or emotional stressful circumstances. And so I'd now like to just present a series of cases. And as I said, spoiler alert here, that all of these patients had ventricular fibrillation. They were all fit and well before their index event. None were taking any medication and none had any prior symptoms. So our first case is Jake. Jake was 21 when he presented with a cardiac arrest in March of 2017. He'd been a little bit unwell for the preceding 24 hours, a bit coryzal, had a mild fever. But of course, this was pre-COVID, where we never really worried about young adults having coryzal symptoms. He took to his bed, and his mum heard him groaning from the next room and found him in cardiac arrest. Paramedics were called and he was thankfully resuscitated. This was his admission ECG when he came to Papworth, or actually to Bedford, his local hospital, then on to Papworth. And hopefully, I'm not sure if my cursor will show up, but he has striking abnormalities, particularly in the right ventricular leads, V1 and V2, and these are typical of a condition called Brugada syndrome. So Brugada syndrome is one of the recognized causes of sudden cardiac arrest in young adults. It particularly affects men, and it particularly occurs during the night. It was first coined as Brugada syndrome in the mid-1990s by 3 Spanish cardiologists who were all brothers, Pedro Brugada being the lead author of the paper, but it's known by many other names in other parts of the world. Brugada syndrome affects people across the world, but it's probably most common in Southeast Asian populations. And in countries like Laos and Vietnam, it goes by other names such as Lai Tai and Bangul Gut, which translate roughly to sudden nocturnal death syndrome. And in fact, there are anecdotal stories of young men going to bed wearing lipstick to try and trick or fool the angels of death who were known to come and take young men during the night. Nowadays, our understanding of Brugada syndrome is a little bit more complete, although still there are a lot of unknowns about it. It is diagnosed by this very specific feature on the ECG called the type 1 Brugada ECG pattern. This consists of right ventricular conduction delay manifesting as a partial right bundle branch block with this typical cove-like ST elevation. It's caused by problems with the conduction and repolarization in the right ventricle, particularly the right ventricular outflow tract, as shown in this 3D electroanatomical map here. It has a genetic etiology, with the sodium channel gene SCN5A being most commonly implicated. A pathogenic variant in SCN5A is identified in around 20% of Brugada syndrome patients, although more recent research suggests that actually it's probably not behaving as a traditional Mendelian monogenic disorder, but has multiple other genes implicated. Treatment is very difficult. There are very few drugs that are effective against Brugada syndrome. And so the mainstay of treatment for people who've either had a cardiac arrest, like our patient, or are deemed to be at high risk, is an implantation of an ICD. And in fact, around 4 years after the initial event, Jake suffered a further cardiac arrest, this time during daytime hours. He's since been initiated on a drug called quinidine and has been free of events ever since. Our second case is Victoria. She was 24. She had gone to bed around 10 p.m., perfectly normal day. She woke around an hour later with sudden chest pain. She was awake at this point. The pain was very severe, but then she immediately collapsed. This was fortunately witnessed by her partner, who again performed resuscitation, and she was defibrillated. This is her admission ECG. Again, maybe the abnormalities are slightly more subtle here, but the diagnostic feature that the QT is prolonged. The T waves are also of abnormal morphology. They're generally low volume, and they have a notched appearance, with particularly seen here in lead 1 and in lead 2, a secondary bump in the end of the T wave. So Victoria was diagnosed with long QT syndrome. She was initiated on propranolol, and subsequently genetic testing confirmed a nonsense variant in the gene KCNH2, which is associated with long QT syndrome type 2. Long QT is probably the most common of the ion channelopathies. It affects around 1 in 2,000 people, and it is characterized by the combination of QT prolongation and the risk of syncope and sudden death due to torsade de pointes polymorphic VT. We have a genetic diagnosis in the majority of people with long QT syndrome, and it's the potassium channel genes KCNQ1 and KCNH2 that are most commonly implicated. These are referred to as long QT type 1 and 2, and account for the vast majority of cases. It's inherited in an autosomal dominant fashion, and like many cardiac genetic diseases, this displays incomplete penetrance. This means that not everybody who carries the genetic change will have manifest phenotype. So these are the three genes implicated and their role in the generation of the cardiac action potential. Long QT is also a good example of where precision medicine is really coming into our daily practice in cardiology. There's good phenotype-genotype correlation between the three most commonly implicated genes and the associated symptoms. The genotype will predict not only the ECG appearance, but the risk of life-threatening arrhythmias and the sorts of things that may trigger them. Long QT1, which is the most common and lowest risk, is typically associated with events triggered by exercise, classically diving into cold water. Whereas long QT2, which is what our patient was diagnosed with, has events triggered by sudden changes in heart rate, so sudden stimulation. And the classic is the alarm clock going off in the middle of the night. This is a figure from that paper, the seminal paper in 1999 by Arthur Wilder. And this is a patient who's got a mutation in the same gene as our patient. An alarm clock goes off at 3 o'clock in the morning, triggering some ventricular ectopics, one of which then initiates polymorphic ventricular fibrillation. Treatment of long QT syndrome is mainly through beta blockade to reduce this sudden change in heart rate and ventricular ectopy, as well as avoiding other situations which may exacerbate the condition, such as QT prolonging drugs or metabolic disturbance. This is David's ECG, the gentleman we met earlier in the presentation. We've already discussed that he, again, was noted to have agonal breathing during the night and was resuscitated by his partner. Again, his investigations were largely unremarkable. The sole abnormality was seen again on his 12-lead ECG and is even more subtle, I think, than the previous two. If I draw your attention to the inferior leads here, leads 2, 3, and AVF, the terminal portion of the QRS is abnormal. There is a notch at the distal end of the QRS, followed by ST elevation. Now, his coronary arteries were normal, and his cardiac MRI was normal. And this pattern is referred to as an early repolarization pattern, and therefore he is diagnosed with early repolarization syndrome. Now, early repol is very commonly seen typically in the anterior and lateral chest leads. It's common in young men, particularly of African ancestry and those who are physically active, and is benign in those groups. However, as demonstrated in this paper by Michel Hassaguer's group from Bordeaux, the pattern of inferior, particularly inferior lead early repolarization, is overrepresented in idiopathic VF patients. So they did a case control study of 200 otherwise unexplained VF survivors and found that this pattern was present in 31% of those patients, compared to 5% of controls, which were from a healthy university student population. They also found that patients who had ER were more likely to get a second event in the coming years after their initial presentation. Subsequent large population cohort studies performed in Finland showed that patients who had this pattern on their ECG were at a higher lifetime risk of sudden death, although the increased risk didn't really kick in, if you like, until the 5th or 6th decade, where these patients were probably dying from more common diseases such as ischemic heart disease. Over the following, these papers were published around 2009, 2010. Over the following 5 or 6 years, there was great concern that this previously thought to be common and benign ECG finding was related to sudden cardiac death. However, the absolute risk to an asymptomatic individual in the general population is extremely low, and we don't treat people based purely on the presence of an ER pattern ECG. However, in the context of a cardiac arrest survivor, it takes on much more significance. Excuse me. Moving on to our fourth and final case, this is Stephen. He's a 27-year-old male. Similar to the previous case, he was noticed to have abnormal breathing around 3 o'clock in the morning by his partner. He was confirmed to have a VF arrest and was resuscitated. He was admitted to hospital and was extensively investigated, and no cause was found. He had an ICD implanted and was discharged. Around 4 months later, so in December of last year, he had a recurrent event, again, very similar, early hours of the morning, no particular trigger, interventricular fibrillation. And this is the recording from his ICD. So he has a subcutaneous defibrillator. So this is a device with the generator is positioned under the left arm, and the shock coil is under the skin but outside of the rib cage, with the shock coil lying in the sternal position. And the recording here is a consecutive single lead, so starting at the top left and going sequentially through to the bottom right. And what you see in the top line is that he is in sinus rhythm with relatively normal QRSs. There's a bit of background interference on the signal. And then just in the second box of the second line, there is a ventricular ectopic occurring very soon after the preceding QRS. So this coupling interval, this time is around 340 milliseconds. And this is likely to land on the middle of the preceding T wave, causing an R on T phenomenon and initiating polymorphic ventricular tachycardia. That's then appropriately detected by the device, the little T notations under the tracing as the tachycardia detection, and then ultimately on the bottom line, successfully defibrillated with a shock and restoring sinus rhythm. So the phenomenon of idiopathic ventricular fibrillation triggered by a short coupled PVC is formally now known as short coupled ventricular fibrillation. This is a very recent diagnosis, and in fact was not first described, but probably both most recently best described in this paper from a Canadian study. So the CASPR registry is a large nationwide study of unexplained cardiac arrest survivors, and has produced much of the data that's aided our understanding of these patients. Christian Steinberg, who led the paper, showed that this group of short coupled VF, so people who have a recurrent episode of ventricular fibrillation initiated with this short coupled ventricular ectopic, have a particularly poor prognosis going forward. So 50% of those patients will have a recurrent cardiac arrest within 5 years, and may be reduced by the use of this medication quinidine, as already mentioned before. The other potential treatment modality is to identify where the ectopic is arising from within the heart and perform a catheter ablation to get rid of it. They normally arise from within the His-Purkinje system, so in the distal conduction system in the right and left ventricle. But the successful ablation requires the ectopic to be present at the time of ablation. And because these things wax and wane quite significantly, timing those procedures can be quite challenging. So having given 4 fairly unusual and rare cases, I'd just like to then describe briefly how we approach these sorts of cases. Now, of course, the diagnosis in most cardiac arrest survivors are not these rare conditions. 3/4 of patients are much older and presenting with typical coronary artery disease, either an acute infarction or the long-term sequelae of previous established infarctions and recurrent scar-related VT. A minority will have evident structural heart disease, so clear evidence of cardiomyopathy on an echocardiogram, but a minority will have an initially undiagnostic or non-diagnostic information. So this study from Paris consecutively collected all cardiac arrest survivors from the Parisian metropolitan area and looked at their diagnosis at discharge. 90% or nearly 90% of those diagnoses were made with the initial combination of ECG, echocardiogram, and angiography, and most of those were coronary artery disease. But a minority, so 12% or 1 in 8 cardiac arrest survivors have normal coronary arteries, a normal left ventricle, and a non-diagnostic resting ECG. And this group is overrepresented in the younger cardiac arrest patients, as we've already discussed. These are referred to as an unexplained cardiac arrest, so this combination of normal coronaries, echo, and ECG. And through clinical assessment, it's been shown that a number of diagnoses can be made either of ion channel disease, as we've just discussed, but also of cardiomyopathy and of other miscellaneous diagnoses. After clinical assessment, if none of these diagnoses is obvious, then the label of idiopathic ventricular fibrillation is used. And the 2 examples we've shown of short coupled VF and early repolarization are thought to be subtypes of this idiopathic VF. So when we're approached with an unexplained cardiac arrest patient, it really does require a large kind of multidisciplinary approach to try and get that diagnosis. So there are lots of groups involved, and at Papworth we have a defined investigation algorithm, which we have in 3 tiers. So tier 1 initial testing is that's going to give the highest yield, followed by routine testing for that 1 in 8 patients where no diagnosis is made. And then finally, we have some discretionary testing. So tier 1 comprises the things that are done almost in the first couple of hours after admission. So clinical assessment through history, physical examination, biochemical analysis, resting ECG, echocardiogram, and coronary assessment. And as I said, that will make the diagnosis in the majority of patients. Those who remain unexplained then may have a diagnosis made through supplemental ECGs. So these are ECGs performed with modified lead positions, looking for things like Brugada syndrome or signal averaged ECGs. Cardiac MRI is very helpful in patients with a non-diagnostic echocardiogram, particularly for diseases of the right ventricle, which are not so easily identified on echo. Exercise testing can be useful, looking for changes in QT measurement or inducible arrhythmias, particularly when the arrest has occurred in the context of exercise. And drug provocations such as ajmaline can also be used to diagnose Brugada syndrome. Those patients who go through that second tier of investigations really then are getting into towards the idiopathic diagnosis. And there we are not systematically, but on a case-by-case basis, considering things like genetic testing, invasive EP measurements and cardiac biopsy, and other provocative tests that are used on a very individual basis. So, showing this slide already, just to focus that the minimal assessment before making a diagnosis of idiopathic VF should include at least an ECG, coronary imaging, echo and cardiac MRI, exercise testing, and ajmaline testing before making that diagnosis of idiopathic VF. And the reason that it's important not to just stop at those first investigations is that making a diagnosis has multiple benefits. Clearly, most of these patients are going to receive an ICD after their cardiac arrest, but other treatments can be tailored specifically to the diagnosis made. Many of these diagnoses have a genetic etiology, and therefore you may want to consider screening other family members to see whether they may be also affected. And then finally, and perhaps most importantly, it gives closure to the patients. Having an unexplained cardiac arrest is extremely disturbing, and patients often live in fear of when the next event may happen. So being more precise about the diagnosis allows us to counsel them better about what the prognosis may hold, and any lifestyle adjustments such as changes to exercise patterns may help. And I think I'd like to leave it there. Thank you very much.
Greg, thank you very much for a fascinating talk. Can you de-share your screen, please? That would be helpful. So before, there's a couple of questions on the chat, but I thought I'd ask one first, which is about age, the age range of some of these arrhythmias. A colleague of mine in Australia runs a genomic service that recently found variants in CALM2 in 4 children that had all died in infancy, and their mother had been imprisoned for their murder. Thought that she was thought to have smothered them, but in fact then they found this genetic defect in all of them. So given you've talked largely about young adults with sudden arrests, is that because that's the real age distribution, or is it because that you don't have a pediatric service and so you only see those guys? And what if these arrhythmias are genetically driven, why are they occurring in young adulthood and not younger?
Yeah, so excellent question. So firstly, I think the reason that we focus on adults is that we don't have a pediatric service. So there are presentations of cardiac arrest in young children, and there's even an overlap with sudden infant death syndrome or cot death occurring in the first year of life, which can also be attributed to similar sorts of genetic diseases. The different genetic conditions do have different peaks of incidence. So things like calmodulin, which can cause a very aggressive long QT, or a form of a CPVT, tend to present in younger life, whereas Brugada syndrome, for example, will typically present in the 3rd to 5th decade. the explanation as to why you can carry a potentially life-threatening genetic change that only shows up later in life, I think speaks to the fact that it's a complex interaction between the genetics and then environmental triggers. Brugada is probably the best example of how we understand the least about the cause of the disease. Probably what's happening in Brugada syndrome is patients are getting premature fibrosis within the right ventricular outflow tract, and that takes years to build up. So it's very unlikely to present in children. And equally, when you get into your 60s and 70s, if you've got that genetic predisposition but have survived that far, you may well have such extensive fibrosis you can't sustain any arrhythmia, and there's a sweet spot in the middle. In other cases, it's the risk is stochastic. So again, in long QT, the longer your QT interval is and the longer you survive with that QT being that long, then the more chance you are going to run into that fatal event.
Okay, so it's a helpful answer. A quick question from Chris Watson. How useful are signals from things like Apple Watches, which can monitor, do ECGs? How helpful are they in helping pin down these diagnoses?
So I think there is a role for wearable technology in cardiac rhythm management and EP diagnosis, but not so much for this sort of diagnosis. Those wearable technologies and the algorithms that go with them are mainly designed to detect atrial fibrillation, mainly because that's the most common condition and also the easiest to pick up from a single channel ECG. You're just looking at RR variability. The sorts of ECG changes that we're looking at are more morphological. So they're changes in QRS morphology or T-wave morphology, which won't be picked up on a single channel ECG, and also has proven to be a struggle for automated recordings. Cardia device, which is one of the smartphone-based ECG recorders, they have published some literature that device can detect QT measurements and differentiate patients with genetic long QT syndrome from controls. But I think we're a little way before that sort of wearable technology will be able to alert us to a risk of sudden death.
Thanks. And Joe Herbert asks, do these channel genotypes affect other organs, as you might expect that they could?
Yes, they can do. So there are many of these ion channels are expressed in the brain. So there are associations between cardiac abnormalities and epilepsy, for example. And the phenomenon of sudden unexplained death in epilepsy may represent an overlap between these two sorts of syndromes. Some of the rarer types of long QT syndrome, such as say Timothy syndrome, can present with a kind of more widespread syndromic presentation. Again, some of the ion channel diseases, so long QT, can cause congenital deafness. So there are certain features, but many of these patients have no outward sign of any abnormalities.
Thanks. Patrick Maxwell has two questions. The first one is just to ask what proportion of these patients have an informative family history, and how many of these, slightly half-related question, how many of the mutations are de novo?
So maybe to answer the second question first, most of the time we do find that the mutations have been inherited from parents. There are certain conditions, so CPVT we didn't really touch on today, but that is a condition affecting the ryanodine receptor gene, and de novo mutations seem to be higher in that condition. But things like long QT, we often do find them in parents. What we also find is there's a great deal of difference between, even within families, in terms of the expression of these genetic changes, so, and therefore the risk of sudden cardiac death. So although a family can all be affected or have the same disease-causing long QT gene, for example, their actual QT measurements and risk of sudden death can be very variable.
And how often is there an overt family history?
Well, so again, because of that incomplete penetrance, there often isn't an overt family history. I can't give you a particular number as such. The other thing is that the family history will often only come to light after one event or after the presenting event. Then you may find that somebody recalls a cousin drowning or having a car accident unexpectedly, and two are put together.
And I'm going to ask a final one. The J wave on the ECG that you showed, my recollection from medical student days is that they're associated with hypothermia. In that context, are they a bad prognostic sign for cardiac outcome?
Excellent question, and essentially no, they're not. So yeah, so J waves in the context of hypothermia, or Osborne waves as they're kind of classically called, are not related to the sorts of things we see with early repol. Having said that, there are a couple of cases of patients who have a cardiac arrest, have early repol in their resting ECG, and then were therapeutically cooled on ITU and then provoked further arrhythmias. So there may be a link, but we don't worry about patients developing Osborne waves as being at risk of cardiac death once they're back to normal temperature.
Greg, thank you very much for that. We should move on, but thank you.
Thank you.
Our next presentation is by Doctors Nickerson and Toms, who represent infectious diseases and radiology respectively. And Emma is at home for self-isolation reasons, so we're going to have the extra technological challenge of her beaming in, but I think that should all work. So Emma, over to you.
Thank you very much. So yes, I'm presenting on behalf of infectious diseases, and Professor Andoni Toms is also presenting.
Can I check? Can you hear me?
Yes.
Yep.
Just seeming to not be able to move my slides.
You can see them.
Oh yeah, there we go. So the first is a case. So so a 48-year-old woman who initially presented to her GP and then was referred to A&E in October 2020. She presented with a 4-day history of severe left thigh pain, had been taken over-the-counter analgesia for that. Bloods done by the GP showed a CRP of 110, an ESR of 84, a slightly raised D-dimer at 669, a normocytic anemia with a hemoglobin of 98, and the white count was normal. On the basis of the raised D-dimer and the muscle pain, the patient had been started on rivaroxaban for a presumptive diagnosis of DVT. The background to this was that prior to this, in August and September, she had been walking in the Peak District and had felt a twinge in her left groin, and the thigh pain had worsened ever since that time. And then what precipitated the presentation was a sudden worsening in the thigh pain for 4 days before coming to A&E. Otherwise, she denied all other symptoms and was deemed to be overall well, and there had been some intentional weight loss. On review in A&E, it was noted that she had a family history, sort of vague joint pain, some arthritis. In the social history, it was noted that she grew up in Japan but had been in the UK for more than 20 years. She'd never smoked and had just 2 to 4 units of alcohol every 2 weeks. On examination of the left groin, there were no palpable lymph nodes or masses. It was mildly tender, and there was no erythema noted. And the left leg was not felt to be more swollen than the right. She was sent. She had a chest X-ray which was normal, and the next day arrives at EAU3 in order to have an ultrasound to rule out a DVT, and is found to have an acute thrombus in the popliteal vein. And so the rivaroxaban that was started by the GP is continued. And then in December 2020, the GP re-refers her with ongoing left thigh pain and persistently abnormal bloods. So the GP had found that there was an ongoing anemia and thrombocytosis. The ESR and CRP were both still over 100. And so she was referred back and seen in EAU3. By this point, she's now developed some intermittent fevers with temperatures up to 39. She's lost her appetite and as a result of that lost 3 kilograms in weight. As a result of being on the rivaroxaban, she's got prolonged menses, and she was also, because now infectious diseases were involved, they asked a few other questions that we get excited about. So it came to light that she'd had shingles in July, so before her trip to the Peak District. And although she had no pets, her last trip to Japan had been in 2019. And although she'd been to Thailand, it hadn't been for more than 15 years. And the CT of her chest, abdomen and pelvis suddenly raised the possibility of avascular necrosis. So then thinking through what her potential risk factors, because this was unexpected, thinking of what medications might have predisposed her to avascular necrosis. She hadn't had any steroids or bisphosphonates. She didn't smoke. The alcohol, as we'd heard, was minimal. There was no recognized trauma. She hadn't had any radiation, not found to have sickle cell or SLE. In terms of HIV, she had shingles, which I guess can be seen as with declining immunity, but hadn't had an HIV test by this point. And then thinking about the other alternative, given that she'd now developed some temperatures, is could this be an infection? So she'd obviously had the temperatures, she had a raised CRP and ESR, which would be in keeping, a loss of appetite, and foreign travel, although not particularly recent. So now I'm going to ask Andoni to talk us through her imaging.
We're starting with an AP radiograph of the pelvis, and there's a helpful yellow arrow pointing to the left hip, which if you compare to the right, you can see that there is demineralization in the weight-bearing portion of the femoral head. And in particular, there should be a thin sclerotic subchondral white line, which you can see on the right, but has disappeared on the left. It's really quite loosened, that subchondral bone. Possibly there's a sclerotic margin around the edge of it. I think on the plain film appearances, you might think of a cause of regional demineralization, such as transient osteoporosis of the hip. There is a suggestion that there is a breach in the subchondral plate, so you worry that it might be complicated by a fracture, or that this was a primary avascular necrosis, which is then complicated by the fracture. Difficult to tell on the plain film. Are you able to move me on? Excellent. So we've got an MRI here. We have a coronal and axial PD proton density fat saturated images. On the coronal image, you can see that there is an odd step in the cortex, which confirms that there is a subchondral plate fracture. And there is a demarcated area of bone marrow abnormality in the weight-bearing portion of the femoral head, and then really quite extensive bone marrow edema in the head, the neck, and going down into the intertrochanteric area. So looking at those features alone, they would be suggestive of avascular necrosis, quite a large defect in the, or abnormality of marrow signal in the femoral head, and a lot of bone marrow edema. But what's unusual is the size of the joint effusion. So we do see small effusions in avascular necrosis and in transient osteoporosis of the hip, but this is a very large one with a lot of joint distension, and the synovium is hypertrophic as well, and all the soft tissues around the capsule and outside of the joint are hyperemic. So that degree of capsulitis and inflammation would be unusual for avascular necrosis and would be more in keeping with infection. Nuclear medicine studies, we have a conventional bone scintigram on the left, which just shows you increased radiotracer activity from methyl diphosphate, which just shows you that there's increased bone turnover in the left hip and is very non-specific. Whereas the Indian label white cell SPECT shows radiotracer uptake in the synovium and in some of the subchondral bone, and is much more specific for infection. So trying to tie it all together, it looks as if the infection would come first, with it would become the hyperemia, then the local demineralization, and the subchondral fracture is then a complication of the local osteoporosis, but the primary driver for the localized osteoporosis would be infection.
Thank you. So she was then admitted for an excision of her left hip, left hip, sampling and a cement spacer and antibiotic therapy. And given she'd had the infection by the time she came for surgery for almost a year, there was a lot of interest as to what this might be. Could it be something really unusual? But actually, despite sending cultures for all sorts of other things, including mycobacterial and fungal, actually what we got was Staph aureus and lots of it. And this was her post-operative radiograph. So she's a very petite lady, and there wasn't actually a conventional hip spacer that was small enough for her. So they had to fashion one using sort of wire and cement, as you can see. But on the basis that there was some bare metal protruding from the cement, which was antibiotic loaded, we had to prolong her antibiotics just in case that any bacteria and biofilm could settle on that exposed metal. She underwent a prolonged antibiotic course and then had a period off antibiotics during which there was no recurrence of her symptoms. And so in January of this year, she came for a left hip replacement. All her theatre samples didn't grow any bacteria. She had empirical antibiotics until the culture results were all through, and then these could be stopped. And I'm pleased to report that she's currently well and mobilising happily pain-free on her new hip replacement. And that's her latest X-ray. So the next case is a 74-year-old man who in January 2021 presented to Harlow Hospital with neck pain and sepsis. He was diagnosed with cervical discitis and osteomyelitis, and at that time there was no positive microbiology. He underwent a neck stabilization surgery in Romford, was treated for 6 weeks with antibiotics. These were stopped, but he felt he had never fully recovered. He developed further symptoms that affected his shoulders and hips, and predominantly it was discomfort in his right hip. Of note, he had, in his past medical history, bilateral hip resurfacings. And the concern had been for ongoing infection with these. And so he had two aspirates of his right hip, which had been negative, along with multiple blood cultures. But of note, all of these had been taken on antibiotics. In June of 2021, he was readmitted to Harlow with a Staph aureus bacteremia, treated for 4 weeks with intravenous flucloxacillin, including his period on OPAT. So they have elastomeric pumps, which enables them to give continuous infusions and therefore narrower spectrum antibiotics. He had a TOE to look for endocarditis as a reason he may have had the Staph aureus bacteremia, but there was no evidence of that. And then in November 2021, he goes to UCH and has a PET scan, which reports that there could be involvement of his sternocostal joint, and he was again treated with intravenous flucloxacillin, but this time, unfortunately, he develops a rash to the flucloxacillin, which curtails the course. And then in January of this year, he presents with lethargy, neck discomfort, general joint pains, and immense frustration. He decides to pick a different hospital, hence he comes to Addenbrooke's to see if we can do any better. His GP had been intermittently doing bloods, and just before admission, his CRP had been 117, so he had been encouraged by his GP to attend hospital. When he was seen, he was moving all his joints, but there was mild discomfort in the right groin on active movement, but no focal tenderness. I mentioned that he had the resurfacing bilateral hip resurfacing, and that's what those look like for those who are less familiar. And hip resurfacings are particularly known for causing metal-on-metal wear debris. So this is, you get a metallosis, which is where you get tissue deposition of metallic debris as a result of the wear. And you can particularly get adverse local tissue reactions as well as a metal hypersensitivity. So the adverse local tissue reactions can involve a pseudotumor. So this consists of increased joint fluid in and around the joint, a thickened synovium, and or local tissue necrosis. And that can lead to pain, implant loosening, and device failure. And the metal hypersensitivity, so there's loss of the cobalt and chromium ions into the bloodstream, and this can cause toxicity. You can get local reactions, and then also because of they spread into the bloodstream. They can also then rarely affect other organs, including the heart, CNS, and thyroid. An aseptic lymphocyte-dominant vasculitis-associated lesion is a histological finding of a chronic inflammatory response to the metal particles, and it's a type 4 hypersensitivity reaction to the cobalt and chromium ions, as was detailed in the recent dermatology grand round about device-related reactions. So MHRA says that anyone who has a metal-on-metal implant, if they're asymptomatic, every 5 years, they need examination, evaluation for swelling and masses, and a check of their cobalt and chromium ion levels. And if they're symptomatic, then every 6 to 12 months, they should have cobalt and chromium ions checked, and an MRI with metal artifact reduction sequence images. One of the challenges is that there's no defined threshold for toxicity of the cobalt and chromium ions, and therefore the recommendation is to just monitor for an upward trend in the cobalt and chromium ions, and that definitive management, if that is seen, is surgical revision. So, Andoni, if you could take us through his imaging, please.
So these are not quite in chronological order, but I'll start with the plain film. You can see on plain radiographs subtle changes associated with adverse reaction to metal debris, and they usually involve osteolysis of the medial calcar, and there's nothing here. They also suffer with avascular necrosis of the femoral neck and osteolysis of the femoral neck as more chronic complications of these resurfacing arthroplasties. Just of note, what you'll see is this is a big bearing. It's a big ball of metal. And the one thing we just don't like in MRI is spherical metallic objects. Linear metallic objects are much easier to deal with when it comes to sorting out the metal artifact. But these are very, very difficult to suppress artifact with, but nothing on the plain film that helps us particularly. The patient had a number of ultrasounds. This is the one that was done on admission to Cambridge, and it's a sagittal view. You can see the common femoral artery dividing into superficial and profundiferous arteries above a superficial mass, soft tissue mass lying anterior to the right femur. And it's very non-specific. It looks very solid and it's avascular. It's got no particular detectable blood flow on Doppler assessment. So the mass itself, I don't like the term pseudotumor because it gets used immediately that we start to see a mass next to a prosthesis, because of course you do get tumors next to prostheses, and it should really be the diagnosis that we apply to a description we apply to a mass once we know what it is. Having said that, if this was malignant, we'd expect it to be much more vascular than it really is. So in a polyethylene hip replacement, you might think of small particle granulomas. Certainly we could think of infection. If it was infection, it wouldn't be acute. It would look more like a phlegmon to have this sort of appearance, or it could be one of the pseudotumors associated with an adverse reaction to metal debris. Other things like amyloidosis are very, very rare. Next slide. This is the FDG PET that was done prior to admission to Cambridge, and I put it up because it's quite interesting in that it detected a supposed radiotracer uptake in one of the sternoclavicular joints, but actually there was no detectable increase in metabolic activity around either of the hip replacements. So there was no suspicion of infection or an active inflammatory process at PET-CT. So these are two images from our metal artifact reduction protocol in MR. The one on the left is called a Maverick protocol. It's very good at suppressing metal artifact, but it comes at a cost of loss of resolution. You can see how blurred the image looks. But between those two yellow arrows, you can see the hyperintense signal, which is the hyperemic tissue, along with fluid encased within the pseudocapsule of the joint. And on the right-hand image is a more conventional stir sequence, but with metal artifact tweaks applied to it, that shows you the ileopsoas bursa, which is distended with fluid. It's a very thin wall bursa, but characteristically in this case, there is a lot of perilesional edema that tells you that this is a very inflammatory process. And this is not typical of an adverse reaction to metal debris, which tends to be a very low-grade indolent process. And I'll show you an example for comparison. So this amount of inflammation is much more typical of an infection than an adverse reaction to metal debris. Go to the next slide. This is an axial T2 weighted image with the patient's hip who has an adverse reaction to metal debris caused by alval. And in these patients, the capsule is very dark black because the capsule is filled with microscopic particles of cobalt and chrome that cause localized dephasing and loss of signal. So instead of a hyperintense margin, we get a very low black signal margin in these very chronic indolent pseudotumors. So it's not at all typical for an adverse reaction to metal debris.
Thank you very much, Andoni. So we were debating in his case whether this was an adverse reaction to the metal or infection. Eventually, we got some cobalt and chromium ion levels back, and they were within the normal range. So that sort of, again, like the imaging, leading us away from a metallosis. And whereas infection, it seems that he's had a previous Staph aureus infection and that it's presumed recurrent over the preceding year. And after 3 weeks off antibiotics, he was beginning to develop intermittent low-grade temperatures again. So we set about to try and make a microbiological diagnosis. He had 4 sets of blood cultures, all of which were no growth. And then on the 26th of January, he had an ultrasound-guided aspirate. There wasn't actually much fluid that was possible to get out of that collection that we saw on his imaging, but we did manage to get 1 ml of sort of bloody aspirate. And after extended culture, we got some Staph aureus growth, which was fortunate because we hadn't got that result from the extended growth when we had organised an ultrasound-guided biopsy to get some bony tissue for both microbiology and histology. The microbiology of that sample didn't actually grow, but the histology also didn't confirm any features suggestive of alval, and there were low numbers of neutrophils. So it did seem that we were dealing with infection rather than metallosis. And this mattered because the surgical management would be different. So if this was infection, he would require a 2-stage revision, and if it had been metallosis, then it would have been a single-stage revision. So he has now been listed for a 2-stage revision, and he's due the first stage of that next month. And then that will be followed by 6 weeks of antibiotics. So a common theme to both these cases is they require prolonged courses of antibiotics. And so there has been fairly recently a trial of oral versus intravenous antibiotics for these prolonged courses needed for bone and joint infections. So the Aviva trial was reported in the New England Journal in January 2019. And I'm just going to take you through that data. So there were 26 UK centres, and we were one of the recruiting centres for this, looking at adults from the age of 18 with a bone and joint infection requiring at least 6 weeks of antibiotic treatment. They were randomised within 7 days of intravenous antibiotics to either orals or intravenous. The exclusions were infections that would require IV therapy, so Staph aureus bacteremia, bacterial endocarditis, a CNS infection, if it was felt that they needed less than 6 weeks antibiotics in total, or if they weren't possible to create both IV and oral options to randomise them, or if there was any evidence that they had either mycobacterial, fungal, viral or parasitic infection. The trial protocol, essentially, if they gave consent, they were then randomised. And if we had the culture results, then you could choose a definitive treatment. If you didn't have the culture results, then that could be, as long as you could come up with both IV and oral options, then they were tailored in light of the culture results, but they had to be on whichever strategy they'd been randomised to by 7 days. And that accounted for the first 6 weeks of antibiotic therapy, after which you could do whatever antibiotic therapy was necessary. And the non-inferiority margin was set at 7.5%. 1,054 patients underwent randomization, 527 to each arm, and roughly similar numbers didn't complete follow-up or were excluded for various reasons as detailed. The endpoints were, so the primary endpoint was definitive treatment failure, and this was determined by an endpoint committee blinded to the randomization. Obviously, an IV versus oral, it wasn't possible to be a blinded study, but the endpoint committee were blinded to the randomization. The secondary endpoints were serious adverse events, line complications, probable or possible treatment failure, resource allocation, quality of life, and adherence to oral medication. The baseline characteristics were very similar between the two groups. The only difference was that there was a significantly more men in the oral group. Not that that would be thought to have any implications for the result, but in terms of age and surgical baseline procedures, they were similar, not statistically different. And then in terms of histological sampling, microbiology sampling, and the predominant organisms that were identified, again, no significant differences between the two groups. In terms of antibiotics, obviously those in the oral group had converted off their intravenous antibiotics at day 7 as per the trial protocol, whereas the intravenous group were maintained on intravenous for 6 weeks, but otherwise the overall length of antibiotic course was this not significantly different between the two groups. And this showed that there was a non-inferiority, so intravenous and oral were equivalent, and that was also true by hospital. So each of the major recruiting sites individually, we line 4 there showed that there was no difference between sites. In terms of serious adverse events, of note, about a quarter of the patients had a serious adverse event. So yeah, it's not insignificant to be giving these long courses of antibiotics. And the only significant differences between them were obviously intravenous line related complications were significantly higher in the intravenous group. And the early discontinuation of their assigned strategy. So more patients switched from intravenous to oral than vice versa compared to their randomization. And of note, there were no significant differences between the episodes of Clostridium difficile diarrhea between the two groups. The other secondary endpoints, the health economic analysis showed that oral therapy was at roughly £2,740 less expensive than the IV therapy for the non-surgical costs, so prescribing, time in hospital, nursing costs. Looking at the patient-related outcome measures, all the scores improved over time as would be expected, and there were no significant differences in the EQ5D3L scores and the Oxford HIP scores, but the Oxford knee scores did do better in the oral group at both 4 months and a year. And treatment adherence was looked at with Moresky questionnaire scoring and also medication event monitoring system, so pill pots that registered every time the pill pot was opened, and it was felt that there was very limited risk that adherence to oral treatment could have affected the result of the trial.
Emma, we're running short of time. So.
Very quickly, in terms of the implications for practice, not all oral antibiotics are equivalent, and the important things you need to consider are bioavailability, bone penetration, the biofilm activity, and the variable sensitivity profiles. And that if the cultures are positive and you've got oral options, then these, if there's good oral options, then that's very acceptable to do. And if it's culture negative, it's much more challenging to predict empirical oral therapy than IVs. But there are some logistical challenges to doing the orals at this time. Just quickly to thank Andoni for presenting the images today and for his work on the bone infection as part of the bone infection team, the other members of the bone infection team, and others who have helped look after these patients. Thank you.
Cool.
Any questions?
Thanks to both of you for that. Yes, we've got time for maybe a couple of questions, but I might ask that these chats stay open and maybe Emma will be able to answer any additional questions online once we're finished. I've got a super quick question, which is, given the results of that very important study, what are we going to do in practice at Addenbrooke's? Are we going to swap over to oral rather than IV in that context?
So one of the challenges is a lot of the patients with bone infection come through the trauma network, and they live miles from the hospital. So while it's an advantage that they can switch over to orals, and it's much less logistically challenging than IV therapy, actually the logistics of getting bloods from local GP practices and patients being able to get bloods done locally and ECG monitoring is not entirely trouble-free. So there is more people we could switch with better infrastructure, and that's one of the things we're looking at with the orthopedic team.
Okay, so
to see if we can set that up better.
Be switching more people, but not everyone.
Yeah.
Quick question from Patrick Maxwell. The first case, the lady seemed to walk around for a long time on her hip and seemed very stoical. And Patrick was wondering, might she have an altered pain response as a result of one of the increasingly identified genetic variants that alter that?
She was very stoical. I don't know, is the short answer. But yes, maybe.
Sort of case where one day I suspect we might be looking. And then final question from Ken Poole, asking about whether metal on metal degradation products influence bacterial growth and potentially modify immune responses in the context of infection.
So infection hasn't been deemed to be a big problem. So they, many of these patients have had to have revisions, but generally that's been because of mechanical failure related to the metal debris rather than because they've been additionally infected. So I don't think it does seem to influence that.
At least on a practical level. Okay, well, I'd like to thank all three speakers for some very interesting cases and interesting topics, and wish you all the best and see you next week. Thanks very much, everyone.